Lung separation requires specific and special anesthesia techniques and equipment.
Indications for one lung ventilation are both absolute indications and relative indications. In other words, there are some situations where you have to put a double lumen tube in or have some type of one lung ventilation or lung isolation to proceed. And if you talk to most thoracic surgeons, anytime they need to do a thoracoscopic procedure or a VATS, they have to have one lung ventilation, although that's not necessarily the case. So absolute indications include isolation of one lung due to hemorrhage or infection. In other words, if you don't isolate one lung that is bleeding, you're going to contaminate the other lung and compromise the patient's stability post-op. Infection is also an indication for one lung ventilation that is of an absolute indication. Unilateral bronchopulmonary lavage, somebody that has one of those fungal conditions where they have to lavage one lung or the other and not spread it to the other side is an absolute indication. Bronchial pleural fistula. Some of the surgery necessitating lung separation. Thoracoscopy is very important to keep the lung down so the surgeon can actually see and do what he's trying to do within the chest. Lobectomy, of course, it's kind of hard to put a staple gun across a lobe and remove it when the lung's going up and down. At the same time, you can always do some ventilation holding in the case of trauma or somebody that just doesn't allow one lung ventilation. Lung transplantation, of course, is very important to be able to isolate the lung, needless to say. Although it can be done, but often if you can't really get good lung isolation, you end up having to go on bypass. Mediastinal procedures with median sternotomy is another indication. Descending thoracic aortic aneurysm, keep the lung out of the way while they got the clamp on. They're trying to do the reanastomosis. Pulmonary embolectomy, esophagogastrectomy, just because of where they're working. Methods of So, in discussions of selective lung ventilation, the left-sided double lumen tube is the preferred mode, as we'll talk about in a moment. Right-sided double lumen tube is available, but definitely suboptimal. Fogarty occlusion catheter is used frequently in pediatrics. Just stick a little catheter down and use it like a bronchial blocker. Jet ventilation to one lung or the other directed by the surgeon. And finally, cardiopulmonary bypass, which is used in some very complex TEE fistula cases. These are some indications and methods of lung isolation. The indication is on the left, a preferred method in the middle column, and an alternative method is listed. It's a very busy slide, but if you'll notice that the preferred method in the vast majority of cases is the left-sided double lumen tube because of the anatomy of the left and right main bronchus. Very few cases you have a right double lumen tube. Usually that's for some type of left main bronchus surgery or some type of really high pneumonectomy involving the sleeve of the left main bronchus. In basic anatomic considerations in this regard, the right bronchus is, of course, that's where the tube wants to go. It's a more acute takeoff, so it's 25 degrees instead of 45 degrees. It's larger. It'll take the tube pretty quickly, and it's very easy to intubate the right main bronchus, as we've all learned by now when you do the amateur hour intubation. It's been at least 2 days since I intubated the right main bronchus myself accidentally. But in general, you can see the right upper lobe is about 2 centimeters from the carina, so it's kind of hard to get a cuff perfectly placed there without it moving and including the right upper lobe. The left upper lobe is much longer, about 5 centimeters, so you end up having much more room to place the tube without occluding the left upper lobe or being out so far as to accidentally ventilate the right side. So in general, just a reminder, the teeth, the cords is about, and looking at this slide, a 5 foot or so person, you're going to end up having 26 to 27.5 depth in centimeters most of the time. You get around 5'5" to 6 foot tall, it's usually 29, and then above 6 feet tall, it's typically 30, 31 centimeters deep. And it's a good indication if you start using a double lumen tube. One of the big things is figuring out exactly how far to put it in. Back in the old days, before we had fiber optic bronchoscopy, the depth that the tube was in was a pretty good idea about where you were, and typically you just shoved it into amount resistance and then pulled it back to 29 to 30, 31 centimeters. But a lot of times putting one lung, doing a double lumen tube for one lung ventilation is a matter of trying to get the tube into about where you think it is and then fine tuning it with a fiber optic scope. Characteristics of double lumen tubes. Robert Shaw is the most commonly used tube. Proximal cuff for the tracheas. Very large, compliant cuff. It's clear, about 10 to 20 centimeters. It seems like you never get the thing filled up. Typically, I'll use a 20 cc syringe on the end of the tube just to keep from having to constantly adjust it. Distal cuff for the bronchus is blue and typically takes up to about 3 cc's. Sometimes you go to 4, but if you do, it's because you put the too small a tube in. The tracheal cuff provides the ability to ventilate, and the bronchial cuff typically provides the ability to separate the lungs. And it's important if you don't really need to separate the lungs at a certain portion of the case, like at the end, you can typically drop the bronchial cuff with no problem. People that try to use the bronchial cuff and pull the tube back out of the bronchus near the end of the operation to look slick, and use the bronchial cuff to separate the oropharynx from the. More characteristics of double lumen tubes. The right-sided versions have a separate slot on the distal end and in an attempt to better ventilate the right upper lobe, as we saw in the previous slide. But in general, you end up occluding the right upper lobe at certain points, if not during all the operation. And the ends of both lumens have a radiopeg line that kind of tell you where the tube is for recognition with a chest x-ray. Tubing is always very clear, so you can observe respiration in either lumen. So the different sizes of double lumen tubes, there's a 41 French or a 6.5 millimeter internal diameter for both lumens for large men. Used to be we'd put a 41 in if they were just like a mutant, if they were Lurch from the Addams family. 39 French, which is for a normal male, or 6 millimeter internal diameter per lumen. 37 and 35 French for females, and a 28 French for really small people. It's very hard to find a 28 French at most hospitals. Placement of the double lumen tube is one of the great mysteries of the universe, but you do it 5 times and you're suddenly an expert. But you don't bend or distort the double lumen tube like you do a regular tube where you like to put a little curve on it. The tube is perfectly made so it will slide down the left main bronchus if you pass it correctly. So you should pass the bronchial cuff through the cords and remove the stylet, and then turn exactly 90 degrees of the double lumen tube corkscrew. And the magic move here is to not turn it more than 90 degrees. If you go to 110 or if you go 70, it's going to typically go down the right main. And the key is to pull up on the chin or turn the head to the contralateral side, whatever makes you feel better. but the idea also is to make sure it's exactly 90. As you can kind of see down here, if it's exactly 90 degrees, it'll slide where it's supposed to go. And sometimes you gotta advance it with against a little bit of resistance because the tube doesn't. So again, you just advance the tube till resistance met, inflate the cuffs and feel for resistance, and check the placement very quickly like you would a regular endotracheal tube. Listen for breath sounds, watch the chest go up and down as you clamp each side. And that'll save you a lot of time if you just immediately go for the fiber optic scope. Often you'll be disappointed because you can't figure out exactly where you are, and this can actually save you 4 or 5 minutes if you accidentally put it down the right side, which occurs when you first start doing it. It occurs with a regular frequency, but after you've done it a few times and you make sure it's turned exactly 90 degrees, it just doesn't happen to you anymore. And this is what happens if it's too deep. You end up occluding the left upper lobe. If it's not in far enough, you end up having some leakage down the right side. If you don't have it in far enough at all, you'll end up ventilating both sides despite clamping the tracheal lumen. And if you're in the wrong side, you'll notice that pretty quickly because you'll see the wrong side of the chest go up, or you won't hear breath sounds on the side that you're supposed to hear them on. Checking for placement of the double lumen tube, again, you selectively clamp the bronchial and the tracheal lumens and ventilate. Open the port and listen for airflow through the clamped lung. And then if you think you're in the correct side and you're pretty happy with everything, then you fine tune it with a fiber optic scope. Before we started using the fiber optic scope, about a third of all of our double lumen tubes were incorrectly placed. Up to 3/4 of them are incorrectly placed, or they're in too deep or not in far enough. Can occur. And it's somewhat useful for secretions, but in general it's just a quick look-see to make sure that you're about where you need to be. Infrequent bronchoscopy may be necessary in some patients, especially large patients, short large patients, and so you never get rid of the scope. You leave it in the room at all times. For a double lumen tube that's gone down the left side, typically the tracheal lumen ventilates the right lung. So if you're doing a right-sided thoracoscopic procedure, you'll be clamping the tracheal lumen. And the bronchial lumen ventilates the left lung. Fiber optic scope is inserted into the tracheal lumen, and typically you go in with the scope and identify the carina first, and then the position of the blue balloon or the bronchial balloon. And this is what you should see, just a sliver of the bronchial cuff going into the left side, and should be visualized as a crescent shape. If you see too much, it's out too far. If you don't see it at all, it could be all the way down past the left upper lobe, so you're only ventilating the left lower lobe, so you've got even more shunt than before. Some people like to look for the part of the double lumen tube right in front of the balloon, which should be a little bit chafed or discolored immediately prior to the cuff. That means that it's just in the right position. Again, the left main bronchus is about 5 centimeters, so you've got a little bit more room for air. Some people like to go into this right side while they're looking to find the 3 different takeoffs of the right upper lobe, which tells you that you're not down the wrong side and you're not disoriented. But typically this little marker up here at the top, the little triangle, kind of tells you that's the very top of it, so that to give you orientation as to the left and right. The upper and lower bronchus are identified to the bronchial lumen, and again, the average safety margin is about 1.5 to 2 centimeters, or 16 to 19 millimeters. So you got a little bit more room with the left-sided double lumen tube. And again, you go in and identify the left upper lobe, and once you've taken a good look at a few of these through the scope, you become very proficient at it. I don't recommend using the fiber optic scope to primarily position the tube or put the tube in the left side until you become really proficient with bronchoscopy.
So the margin for error being kind of low with placement of double lumen tubes and positioning, especially with the possibility of pushing air over into the operative lung, there's a wonderful new device called a VivaSight. I have no conflict of interest. I wish I did have stock in the company. But basically, you've got a camera on the end of your double lumen tube, not at the end, but actually at the end of the tracheal lumen, such that you're able to see exactly where your double lumen tube is in the position. And in this position, you can see that there's a little bit too much of the balloon that you see, and you can actually even see an air bubble coming out of it, such that we're actually ventilating the operative lung. In this regard, you can actually manipulate the tube, and you can actually even see the tube go down as you place it. And you can, at this point, with this patient, you would aspirate air from the bronchial cuff, advance the tube probably about 1 centimeter until you just see the rim of the balloon, and then you would reinflate the cuff and then probably suck on that lung and drop it from there.
So typically the blue tip of the endobronchial cuff, if you're going down the bronchial lumen, is used to identify to assess depth. If you're not in too far, you can see the takeoff of the left upper lobe here and a continuation of the left main bronchus down here as the left upper lobe. Indications for right-sided tube, typically a really high left pneumonectomy, left-sided tracheal bronchial disruption as Mr. Ford and I had, or tracheoesophageal fistula, mediastinal lesion compressing the left main stem bronchus, which makes it kind of difficult to position the tube in the left main bronchus. Sometimes there's a left bronchial stent from somebody that has a compression of the left main bronchus. Some people don't like to put a left-sided tube in for a left lung transplantation, but they've gotten around that after having to deal with issues with the left main with a right-sided tube. So typically they'll use a left-sided tube for a left lung transplant anyway. And then again, if you've got a thoracic aortic aneurysm that's compressed in the left main bronchus, you'll go with a right-sided tube. But again, I've put in 5 right-sided tubes in my life, and I had pain and agony and torture with everyone. And this is a right-sided tube, and you can kind of see the little hole here that supposedly helps you ventilate the right upper lobe, but it really doesn't work at all. It's just so difficult to position. You're constantly going in and out with a fiber optic scope. You don't get anything done. Right-sided double lumen tube confirmation, typically once you verify that you've got the cuff just barely in the right main bronchus, you have to continuously go in the bronchial lumen and find the takeoff of the right upper lobe here through this little hole. And it's just a complete pain because you've got to constantly torque the scope up at 45 degrees to see it. So let's talk about some physiologic considerations during one lung ventilation. You have some problems with baseline pulmonary status in general because they've got obstructive versus restrictive disease. They've got baseline hypoxemia and hypercapnia. On top of that, you've got the issue of position, which is in the lateral decubitus position, which is not necessarily physiologic, but really helps you out with one lung ventilation. You've got open chest versus closed chest and the usual effects on your distribution of ventilation and perfusion. And you've got clamp issues as well. You have management of ventilation. You end up having to modify your I/E ratio. You have to modify your different ventilation modes between ventilation control or volume controlled and pressure controlled ventilation, along with the addition or subtraction of PEEP. So just a couple of things about your assessment of your patient. It's good to know your FEV1 or your forced expiratory volume in 1 second. FEV1 is the volume exhaled in the first second of your your FVC during spirometry. And it's expressed in as an absolute volume or a percent of the predicted value. The value itself is very useful as far as figuring out whether you've got some restrictive deficit, but more importantly, the percent volume kind of tells you whether they've got obstructive disease, which kind of dictates change in your I/E ratio as well as your ventilatory rate and predictive value of their ability to maintain their SAT post-op. Forced vital capacity is very useful in predicting restrictive disease, which can be assessed by measuring the vital capacity exhaled as rapidly as possible. And as we talked about in the previous class, an FVC of less than 2 liters is predictive. Restrictive lung disease or muscle weakness, abdominal swelling or pain can be suspected with a low FVC. And you can predict some degree of a lower FVC post-op just because of the pain associated with this operation. Post-op pain management is a very big part of any thoracic procedure. The thoracic epidural and a functioning thoracic epidural is very key in this regard. Spirometry, again, FVC, FEV1, FEV1, FVC in this case is 90%. You think, well, very healthy. Well, actually, it's because your FVC is only 1 liter, which is only 40% predicted. So your FEV1 is actually low as well, but the FEV1 FVC is very high, giving you an idea about how one value in and of itself does not give you a good prediction of the patient's pathology. So let's discuss lateral decubitus position and its effect. Most thoracic procedures in one-lung ventilation, with the exception of some esophagectomies and some spine procedures, are performed in lateral positions with the table flexed. It predisposes to nerve and eye injury, especially brachial plexus injuries and eye injuries, and significantly alters the normal pulmonary VQ relationship, so you get an increase in shunt and hypoxemia compared to supine positioning. And a lot of this is if you have a lateral decubitus position, you've got the mediastinum pushing from above, you've got the abdominal contents pushing from below, the shoulder and suboptimal positioning not allowing full lung expansion, so you end up having a lot of atelectasis in a dependent lung. You end up having most of the ventilation going to the top lung if you're ventilating both lungs. So you end up having blood in the dependent lung, but the ventilation in the top. So you have ventilation perfusion mismatch as described classically. Anesthetic choices, you have inhalation agents and opioids. A good mixture is usually very useful, especially if you've got an epidural, a good thoracic epidural, and where you can work in a little bit of 0.125% bupivacaine, usually about 3 to 9 cc's, and not overdo it to where you end up having hypotension. But in general, inhalation agents, you have good bronchodilation, which is very good for your VQ ratios. You have decreased airway irritability, and just a nominal decrease in your hypoxic pulmonary vasoconstriction up to 1 Mac. You also ensure amnesia, and it also goes away very quickly, which is nice if you're extubating these patients, which is very important in post-op management and patient satisfaction. Opioids, you have no significant hemodynamic depression and a smooth transition into emergence with minimal decrease in HPV, but then once you get. And in discussing use of inhalation anesthetic and shunt, typically you go lateral. 60% of your blood is in the dependent lung, 40% is in the non-dependent lung, so you end up having a tremendous amount of shunt ordinarily. But if you drop one lung and you go one lung ventilation, you have 80% of the blood flow in the dependent lung. As you know, typically the alveolus and the pulmonary capillaries run together like strands of a rope. So if the alveolus is collapsed, the capillaries collapse as well. So most of the blood is in the dependent lung, about 80%. So you have about 20% shunt. So when you add a MAC of any inhalation anesthetic, you typically get a 4% increase in shunt. So you end up having a 24% shunt. So that's still manageable if you're running 100% oxygen. And typically, if you have minutes of one lung ventilation with 100% oxygen plus an anesthetic, about 40 minutes out, you end up having a PO2 that goes from 400 down to about 150 or so with CVO and ISO, a little bit more with DES. I think it's because DES you typically have to run 6%, so your FO2 is only about 0.94 or so. And I can't tell you which agent's best. It's all operator dependent. I'll typically use sevoflurane just because of its salutary effect on bronchoconstriction and bronchodilation. It's a little bit better agent than ISO. So initiating one lung ventilation, you position to protect the nerves and minimize compression of the lower lung. Typically, you recheck the double lumen tube position because it can migrate in or out. So if it goes in too far, you end up occluding the left upper lobe. Out too far, you're suddenly ventilating both lungs, or there's at least a little bit of a leak so that the operative lung comes up and the surgeon says, oh my gosh, you're ventilating this lung, and then it's the end of the world. And once you turn, you should always initiate one lung ventilation immediately after positioning. And you think, well, why don't you just keep ventilating one lung and then you have less hypoxemia and you don't have to deal with it as early? Actually, it takes a while for that lung to come down. So if the lung is up, the surgeon can't work because the lung is in his face. And as well, there's other little issues. A lot of the surgeons like lower tidal volumes because the mediastinum moves. And again, it's not, they don't like a motion. Initiating one lung ventilation typically involves changing the ventilator settings. You should have lower tidal volumes because you have less area. So typically your peak pressures will go up. You try to seek a peak inspiratory pressure between 20 and 30 centimeters of water. The thoracic surgeons will say no more than 20, but that's just because they're worried about lung trauma. I typically manage my peak inspiratory pressures less than 30. I always go with an FiO2 of 100% just to give myself a little bit of a safety margin. A lot of people I see in a teaching practice will go with 50% because they believe the whole absorption atelectasis thing that was touted, but typically that doesn't happen in a 3 or 4 hour operation. I would recommend considering the use of pressure control because you get more of a decelerating inspiratory phase. You get a little bit better recruitment of alveoli instead of the use of. So typically in two lung ventilation you have about a 60% of the blood in the dependent lung, 40% in the top lung, and your shunt's about 10%. Your PO2 is about 400. When you clamp the ventilation to the operative lung or the non-dependent lung, typically your fractional blood flow or the shunt's going to be about 25%, 27%, around in there, and your blood flow is going to be about 77.5% to the dependent lung and 22.5% to the non-dependent lung. And this varies a lot. As we'll talk about in a moment, a lot of factors influence how much blood goes to that operative lung. And these are virtual shunt lines, as you can kind of see here. We're talking about 20, 25, 30% shunt. So typically, if your FiO2 is 100%, going up from 50% to 100% isn't going to help you out a lot if your shunt is 25% or more. But if it's 25%, 20%, you can get a big benefit. And you can actually have a PO2 of 250 if you've got about a 20% shunt, if you're really optimized. If the surgeon's really mashing the lung, if you've got good isolation with that lung, all that, it works out actually pretty well. And that's why you see a lot of people using 50% FiO2 for an unknown reason to me, but in their mind it avoids absorption atelectasis. Other factors affecting the degree of shunt, whatever atelectasis you've got in the surgical lung where there's no ventilation is going to promote HPV, and you're not going to have as much shunt. Systemic vasodilator drugs may inhibit HPV if you're using some nitroprusside. More specifically, if you're using a higher than 1 MAC of an agent, you're going to have inhibition of HPV. Higher pulmonary artery pressures if you have pulmonary hypertension. Some people feel like HPV is inhibited by decreasing the ability of the vessel to constrict. Haven't seen that a lot, fortunately, but it is a theoretical concern. Lower FiO2s inhibit HPV by constricting flow to normoxic lungs, so that may be an issue with using 50% oxygen. And these are some of the factors that are influencing the degree of shunt you've got. You've got surgical interference up here at the top where the surgeon's actually mashing the PA. Actually, he can put a suture around the, or a ligature around the PA, or a bulldog around the PA, the pulmonary artery, if he's going to take that lung out anyway, or even a really good thoracic surgeon can ligate the flow to the lobe he's working on and help you out if you're struggling. Any HPV is going to help you out. Any lung disease, if you've got lung disease, you don't have a lot of blood flow to that silent unit anyway. Gravity is a big determinant of flow to that non-ventilated lung as well, and the more gravity you've got, of course, you're going to have a good bit of protection against shunt. RV function is a determinant. The amount of ventilation going to the dependent lung is going to affect management of hypoxemia during one lung ventilation. First thing you do is notify the surgeon. Surgeon's got to know. If it's less than 90%, he has to know, because he may have to stop what he's doing so you can put some oxygen in that lung and decrease the shunt. Rechecking the double lumen tube position using the fiber optic bronch is the very next step that you do, because the tube could be in a little bit too far. Very frequently done. Suction of dependent lung, recruit the dependent or ventilated lung, recruit as many alveoli as you can with different ventilation modes, optimal PEEP, things like that. Some people like to put a little oxygen from the side arm into the operative lung via some insufflation. I don't think that really works very much. Change ventilator modes, like I said, the IDE ratio, all those things, optimization. But typically, if you have hypoxemia, it doesn't really respond to the oxygen. It doesn't really respond to too much ventilator modes. Sometimes it's a matter of repositioning it. Other things you can do to manage hypoxemia, dependent lung PEEP. Sometimes some CPAP to the operative lung is very effective, especially if you're putting PEEP to the dependent or ventilated lung. Problem with putting CPAP to the non-dependent lung is it's going to blow the lung up a little bit, make the surgeon angry, give him a moving field. Sometimes putting just a little bit of oxygen in the non-ventilated lung works as well, because then there's oxygen to match the blood flow in that surgical lung. Problem with that is you're again, you may be blowing up a piece of the lung that the surgeon's working on, and that's a big issue. But I've found that if you communicate with the surgeon, you can often just put a little oxygen in if you really have to while you're troubleshooting a double lumen tube. Consider intermittent ventilation of the non-dependent lung. Sometimes the surgeon will let you put a little oxygen in and then reclamp and open the lung and let the air come out. And then again, the surgeon can put a one lung ventilation using PEEP to the ventilated lung is very useful because you recruit alveoli, but at the same time you're going to have more blood go to the non-dependent or non-ventilated lung, so you end up having more shunt. So ways of getting around that is CPAPing the non-ventilated lung if it doesn't cause problems for the surgeon. And this is just a nice little graph. Shows arterial hemoglobin oxygen saturation in the abscissa, and then the ordinate shows minutes of one lung ventilation. You can kind of see about 10 minutes out, you start to desaturate. You put a little PEEP to the right lung, it makes it even worse because now you're shunning more blood to the non-dependent lung. You CPAP the left lung or the non-ventilated lung, and you end up having a little bit better equalization of intrathoracic pressure, so you end up having a little bit less shunt. I found pretty much that putting 4 or 5 centimeters of water of PEEP to the ventilated lung doesn't really cause too much of an issue. It's when you start to get up around 6, 7, 8 that you start to have more blood going to the non-ventilated lung and having shunt and hypoxemia. So when can you not use a double lumen tube? Well, when you're unable to replace the existing endotracheal tube. Sometimes folks are up on the floor with an endotracheal tube in, and you just, their SAT's 91, 92% on 50%, and you just don't think that you've got the ability to swap it out. A Cook catheter is very useful in that you can often just put the Cook catheter in like a stylet, pull the single lumen tube out and replace it with a double lumen tube, and then position it with a fiber optic scope. Cook catheter is very useful as well. As you can see here, while the Cook catheter is down, if you're having some issues, you can always ventilate just a little bit through this hole here in the Cook. Again, if you can't maintain adequate PO2 with one lung ventilation, they can't handle the shunt. There's too much shunt. You just can't replace it. Again, there's absolute and relative indications for one lung ventilation. Depending on the surgeon, they should be able to get by with complications of double lumen tubes are many. Hypoxemia can be an issue, and that's considered a complication. Tracheal bronchial tree disruption. If you've got a double lumen tube and you shove it in, you can tear the bronchus, as you can kind of see here in this wonderful picture. Traumatic laryngitis. Double lumen tube becomes a temporary part of the suture line. That's always bad. If you put a left-sided double lumen tube in, you do a left pneumonectomy, surgeon sews the tube into the suture line, you go to extubate, nothing happens. Bronchial blockers are another way of securing one lung ventilation, and a lot of people are really high on bronchial blockers, but the vast majority of us just absolutely despise them because of the slow deflation time. You get blockage of the bronchial blocker by blood and pus, constant need to reposition. It's very painful. But it can be positioned during continuous ventilation in lateral decubitus position. No need to change the tube after the procedure. It's convenient in that regard. If you've got a trach in, that, like if you have a patient that comes in with trauma and you've got some air leak and you got to go in and do a VATS or something like that, it's very useful for that. But in general, you just end up having to fight with it, and the surgeon complains about the lung constantly. And this is a univent, which is a bronchial blocker built into endotracheal tube, which is something that was used for a while, about 2005, 2004, just out of convenience. But it's a very big tube. It's about a 9 millimeter external diameter tube, which is actually an 8. But because of the bronchial blocker, it's a much larger profile. Fiber optic positioning of a bronchial blocker, you can't just shove it in and put the blocker and expect it to go down the correct lumen. Typically, the 2 millimeter bronchial blocker can be used for a lobe or lung collapse. And it's a high volume, low pressure cuff, which requires 2 to 8 cc's of air. You don't know exactly how much of it to put in, but in general, it's 2 to 8. And the tube size ranges from, again, 6 to 9 millimeter internal diameter, which represents anywhere from 7 to 12 millimeter external diameter, which is a pretty darn big tube. Wire guided into bronchial blocker, or a web, is very commonly used. As I said before, you got about a 1.4 millimeter internal diameter lumen of this tube with a flexible wire extending to the distal end, which you can kind of see here. And the fiber optic bronch is coupled with the web. Typically, it's you stick this little loop around the fiber optic scope, and then use the fiber optic scope down a single lumen tube, and then thread the bronchial blocker over the top. And you got a 3-way multi-port adapter used for fiber optic bronch, the blocker port, and the anesthesia circuit. And this is this 3-way here. You've got one port here to put the blocker through. You got another port here for the fiber optic scope, and then you got another port over here for the anesthesia circuit. And you can kind of see the little loop down here that is threaded over the bronchial blocker. This is all attached, not attached to the circuit until after you put the blocker in, then you put the fiber optic scope through, and then you put the little loop around the fiber optic scope, and then you put everything in the single lumen tube, and then just intubate the left main bronchus or right main bronchus with the fiber optic scope, and then thread the blocker over the top of it. Indications for a web, again, you got an existing endotracheal tube that you can't swap out, or a trach in place, rapid sequence induction and one lung ventilation, known and unknown difficult airway. Sometimes they're just a difficult airway, and you can get a single lumen tube in, but you can't get a double lumen tube or a Cook catheter in. Nasotracheal intubation, small adults, it's very useful. If you want to just block one lobe or another, it's very useful. If you're just, for instance, taking out a right lower lobe, you can actually block that the right lower lobe and not ventilate it, but still ventilate the right middle and the right upper lobe, which is very useful for people that can't tolerate one lung ventilation classically because of hypoxemia and shunt. And finally, trauma. Again, they come rolling in. They've got a gunshot wound to the chest. They got an existing tube. You know, between putting the RIC line in and the A line and the central line, you don't have time to do anything else. So you just stick a blocker in, and works very effectively. And in summary, the left-sided double lumen tube is the most versatile method for one lung ventilation. Positioning fiber optic bronch is a necessity. It's not a skill you pick up in simulation. It's something you got to pick up in the OR because the depth perception, the secretions, the amount of light, and constant focusing is a problem. Optimizing shunt is a 12-step program. There's all sorts of ways you've got to use to optimize your ventilation perfusion ratios, including alveolar recruitment, including de-recruiting the operative lung with surgical compression, maybe ligating the vasculature. And bronchial blockers are useful if already intubated or got a trach, but they have serious limitations. I recommend highly that you always use a left-sided double lumen tube whenever you're doing one lung ventilation.